So, okay, now I'm going to talk about the ducts of the pancreas. And to understand the duct of the pancreas and the normal variability of the sides of the ducts of the pancreas, we have to understand a little bit about the embryology of the pancreas. Okay, that pancreas, beautiful pancreas that we see, is a result of connection between the dorsal bud of the pancreas and the ventral bud. Okay, I'm not going to get into what is the dorsal bud and the ventral bud. Just want you to know that we have what we call the ventral bud and what we have the dorsal bud. And when the gut rotation during pregnancy, okay, when we have what we call the gut rotation, the ventral bud will join the dorsal one. Okay, the ventral will form the inferior part of the head of the pancreas and the anicinator process. Okay, and the dorsal bud will form the rest of the pancreas. Okay, so we have some ducts of the pancreas, and these ducts, as we will talk later, the function of these ducts are to drain the exocrine secretions of the pancreas. As we all know, we have an endocrine and exocrine secretion functions of the pancreas. Okay, the endocrine, from the name, will drain into the blood vessels. Okay, but the exocrine secretions will be secreted through the pancreatic ducts into the duodenum to do its function, which is the digestion of starch and so on. Okay, I'm going to talk about that in details after that. Okay, but the important thing to understand that in the ventral bud we have what we call the duct of Versung. The duct of Versung is in the ventral bud. Okay, and the duct of Santorini is in the dorsal bud. In the dorsal bud. So after the effusion of the dorsa and the ventral buds, we will have one pancreas with the Versing duct here and the Santorini duct here. Okay, so this is the large one. The main pancreatic duct is the Versing duct, and the accessory duct is what the so-called Santorini duct. So in 60% of cases, most of the pancreatic secretions, exocrine secretions, will go into these ductules and into the main duct of the pancreas and move and will go into the Versing duct. Okay, into what we call the greater papilla, or the papilla of Vater, or the ampulla of Vater, whatever you want. Okay, so and drain there. A smaller amount of the exocrine excretions of the pancreas will go into the Santorini duct. Okay, and will discharge or will secrete the secretion of the pancreas in what we call the laser or the accessory papilla. So the greater papilla is the papilla of the Versing duct, which is a result of ventral bud. Okay, and will drain into the duodenum. The lesser or the accessory papilla is the continuation of the Santorini duct, which is from the dorsal bud, that will drain a smaller amount of the pancreatic excretions into the duodenum. Okay, so this is in 60% of cases. So I am telling you that this is in 60% of cases. What about the rest of cases? In other 30% of cases, as a result of some embryological normal variants, okay, the accessory or the laser papilla will not open in the duodenum. Okay, it will be blinded or ended in the parenchyma of the pancreas. So all of the exocrine excretions of the pancreas will go into what? Yes, the greater papilla through what? The Versing duct. Okay, the Versing duct. So this is in 30%. 60% of cases we have two ducts, the laser or accessory duct and the greater duct. Okay, and both of them will discharge into the or secrete into the duodenum. In 30% of cases, the accessory duct will be blinded. It will not be in use. We only use the Versing duct which is the continuation, the baby of ventral bud. Okay, in 10% of cases, this effusion of two ducts, the process of effusion of two ducts embryologically, will fail. Okay, and the versing duct or the will not join the Santorini duct at all. There will be no point of connection between them, and that will result in the versing duct sadly is alone. Okay, it's not connected to the main pancreatic duct. And what really happens here is that the pancreatic secretions will secrete into the minor papilla, and this is in 10% of cases. And sadly, the minor papilla diameter is smaller diameter than the greater papilla. As you can see here, okay, the name of it is a greater papilla, and this is the laser papilla. And now in this 10% variant, all of the exocrine excretions of the pancreas will drain into the minor papilla. Okay, and that in some cases will lead to failure of this minor papilla to cope with this, and that will lead to accumulation of enzymes in the pancreas and to pancreatitis. And the surgical treatment of that is minor papilloplasty. Okay, so this is from a embryological point of view to make you understand the normal variability of the pancreatic ducts. Okay, so 60% we have this case, the 30% we have this case, and the poor 10% we have this case. Okay, so this is to understand. Now let's talk about the pancreatic ducts. We have the major duct, and we have here the ductules, which are linked to what we call the acne. I'm going to talk about them in details after that. Okay, and we have the versing duct and the Santorini. What is that? This is the bile duct coming from the liver, draining into the as I told you before, it will go into the posterior part of the pancreas and get into or run into the parenchyma of the pancreas, and eventually it will go to the versing duct and join with it to drain what? To drain bile into the duodenum through the ampulla of Vater. Okay, so this is the product. The important question that you may ask me now, why don't the secretions in the bile duct just get in retrograde movement through the pancreatic duct? And the answer is, the pressure inside the main pancreatic duct is about twice more than the bile duct. Okay, so that will prevent the retrograde movement of secretions of bile duct into the pancreatic duct, so they all will move here. Okay, again, we may have a variability of bile duct drainage. Some of the bile ducts will open into the versing duct. Some of them will open in another opening just to the side of the pancreatic duct or versing duct in the greater papilla. Around the greater papilla, we have we have what we call the sphincter of Oddi. Okay, and the sphincter of Oddi is a result of the muscle contraction or muscle concentration in this area, and this will control the secreting of pancreas into the duodenum in response to some hormones and neural effects. Now I want to ask you a cute question. Okay, what is the distance between the greater papilla and the lesser papilla? The answer is 2 centimeters. Now the blood supply of the pancreas, actually the blood supply of the pancreas will come from the great celiac trunk and the great superior mesenteric artery. Okay, so the celiac trunk, the way that supplies the pancreas is by giving the common hepatic artery. Okay, and the common hepatic artery will go as hepatic artery propria to the liver. But before that, it will give what we call the gastroduodenal artery. So the celiac trunk, common hepatic artery, the gastroduodenal artery. This gastroduodenal artery will look at the duodenal and the pancreas and say, oh, the poor duodenal and the pancreas, I'm going to give them blood to live, okay? And as a result of that, the gastroduodenal artery will give the anterior and the posterior pancreatico-duodenal artery, anterior and posterior pancreatico or pancreatoduodenal artery, okay? These are posterior, anterior and posterior, right? But they are also superior anterior and posterior pancreatico-duodenal artery, okay? So the superior blood supply of the head and the neck of the pancreas is from the celiac trunk, the common hepatic artery, the gastroduodenal artery, the anterior and posterior superior pancreatoduodenal artery eventually, okay? So this is about the superior, anterior and posterior areas of the pancreas. What about the inferior part? Actually, the superior mesenteric artery will give the anterior and posterior, again, pancreatico-duodenal artery. Just notice that the pancreas and duodenum, this part of the pancreas and duodenum are supplied together from the same branches, okay? So we have superiorly the superior pancreatico-duodenal artery, anterior and posterior, from the celiac trunk, okay? Inferiorly, we have the anterior and posterior pancreatoduodenal artery, but the inferior branches of the anterior and posterior pancreatoduodenal artery. So you can know him by logic, okay? So the superior and the inferior. Superiorly we have anterior and posterior pancreatoduodenal artery. Inferiorly we have anterior and posterior pancreatoduodenal artery. Okay, the superior branches from the celiac trunk and the inferior branches from the superior mesenteric artery. And the beautiful thing happens here that the inferior and superior pancreatico-duodenal arteries just join at the medial aspect of the head of the pancreas, at the C-loop of the duodenum side of the pancreas. These superior and inferior pancreatico-duodenal artery, the anterior and posterior branches of them, join together to form the arcades of the pancreatico-duodenal artery that will supply the duodenum and the pancreas at this area. And as a result of that, it is impossible to resect the pancreas, okay, without devascularizing the part of the duodenum, that part of the duodenum, unless you can keep a part of the pancreas that have the arcades, okay, so that you can preserve the vascularization of the duodenum that way, okay, and you can't preserve that in any other way. In about 15 to 20% of cases, we have some variability and normal anatomical variability, okay? So this anatomical variability is that the hepatic artery will come from the superior mesenteric artery, not the celiac trunk, okay? So the hepatic artery will be a branch of the superior mesenteric artery. It will come like that, okay? So from the superior mesenteric, we have the common hepatic artery, and the same thing about the gastroduodenal artery. So the gastroduodenal artery will come from the common hepatic artery that will come from the superior mesenteric artery in about 15 to 20% of cases. And it's important to know about this because in CT scan, so that the surgeon can know the anatomy of the blood vessels of the pancreas and can't hurt the patient when apply a surgery for any reason, okay? This is about the head and the neck of the pancreas. What about the body and the tail of the pancreas? What is the blood supply of them? As obvious here, the splenic artery is the main blood supply of the tail and the body of the pancreas. And how does it do that? Actually, the splenic artery, which is the tortuous, beautiful artery that links that comes out from the celiac trunk, okay, will give some parallel branches, okay, as you can see here, the caudal branch, the greater branch, and the dorsal branch. The names are not just not here, but you know them: the caudal, the greater, and the many branches. Okay, that will join the what we call the transverse pancreatic artery, and again they will make some kind of anastomosis or arcades here. Okay, so the splenic artery will give these branches that with the a transverse pancreatic artery, and they will supply the body and the tail of the pancreas. And this is other photo from Schwartz that will show that we have the splenic artery, okay, and the parallel branches of it: the dorsal pancreatic artery, the great pancreatic artery, and the caudal pancreatic artery. They will anastomose with the dorsal pancreatic and okay, sometimes we have in some books the inferior pancreatic artery, which is a branch of the superior mesenteric artery. This inferior pancreatic artery will join the splenic artery to supply the tail and body of the pancreas. In other books we can see that the transverse pancreatic artery is the thing to join the splenic artery to supply the body and the tail of the pancreas, and it's a branch of the celiac trunk, the transverse pancreas artery. So again, the blood supply of the pancreas, the head and the neck, and the body and the tail. The head and the neck are mainly supplied by the celiac trunk and the superior mesenteric artery. The celiac trunk is responsible for the gastroduodenal artery, which will branches into the anterior and posterior superior pancreatic duodenal artery. Okay, the superior mesenteric artery and the other side will give the inferior, anterior, and posterior pancreatic duodenal artery. Okay, and for the body and the tail of the pancreas we have the splenic artery, what will give the dorsal, the great, and the caudal branches that will supply or make some connection with the transverse pancreatic artery and supply the body and the tail of the pancreas. So in the next video I'm going to talk about the venous supply of the pancreas. Thank you very much for watching.